Hi, I'm Charlotte Grinnell. My guest today is Dr. Anna Lembke. Dr. Lembke is an associate professor and medical director of addiction medicine at Stanford University School of Medicine. She is also program director of the Stanford Addiction Medicine Fellowship and chief of the Stanford Addiction Medicine Dual Diagnosis Clinic. Dr. Lembke was one of the first in the medical community to sound the alarm regarding opioid overprescription and the opioid epidemic. In 2016, she published her best-selling book on the prescription drug epidemic called Drug Dealer MD: How Doctors Were Duped, Patients Got Hooked, and Why It's So Hard to Stop. Her book was highlighted in the New York Times as one of the top 5 books to read to understand the opioid epidemic. Drug Dealer MD combines case studies with public policy, cultural anthropology, and neuroscience to explore the complex relationship between doctors and patients around prescribing controlled drugs. It has had an impact on policymakers and legislators across the nation. Look for her new book coming out, Dopamine Nation: Finding Balance in the Age of Indulgence. Welcome, Dr. Lembke. Thank you so much for joining us to discuss this fascinating topic.
Well, you're very welcome. Thank you for inviting me.
Yeah, so could you start by telling us what inspired you to write your book, Drug Dealer MD?
I was inspired to write Drug Dealer MD because I was seeing so many patients coming in who were becoming addicted to the very medications their doctors were prescribing them. This included primarily opioids, things like OxyContin, Vicodin, morphine, fentanyl, but also other psychotropic medications like benzodiazepines, Xanax, Valium, Klonopin, as well as stimulants like Adderall. And because I saw the negative effects on my patients of these prescriptions, I felt it was my responsibility to learn more about addiction, but also specifically to learn more about what were the systemic forces driving overprescribing that was leading to harm of patients. Because I knew that the vast majority of my colleagues go into medicine to help people, and that many of the doctors that were prescribing the medicines that were harming the patients that I was seeing were good doctors, are good doctors, but didn't realize the addictive potential of the medications they were prescribing. So that's really what motivated me, as well as what I learned in the process of writing my book, which was that there were enormous invisible incentives inside of medicine that were driving this phenomenon, not based in evidence. So when I looked at the evidence, I saw, wow, there's a real big gap between what the evidence shows these medications can do and what the medications really can do. And I kind of wondered what's driving that gap, and I discovered that there are a lot of sort of, let's say, key players that are really invested in having doctors prescribe these medications, including the individuals who make the medications, distribute and dispense the medications. So the pharmaceutical industry, I discovered, had a huge hand in this.
Definitely. That's such an interesting topic, and one that I think is not discussed as much as it should be. And how specifically was the physician's role in the opioid epidemic in contributing to it?
Right. Well, prior to the 1980s, 1990s, doctors used opioids very, very sparingly because they were concerned that their patients would get addicted to opioids. And that concern was not based on sort of hypothetical concerns. It was based on historical precedent. So in the late 1800s, early 1900s, doctors began prescribing morphine and then even heroin, which was supposed to be the non-addictive formulation of morphine, to patients, to soldiers, to little babies getting over, teething. And in that process, a huge number of individuals became addicted to opioids. So we already had the example of doctors prescribing opioids to patients getting addicted and then not being able to stop and having all these horrible consequences. So we knew historically that we had to be really careful. And that's why a whole series of legislation was put into place to make sure that these molecules, opioids, which are absolutely indispensable in certain medical situations, don't get overutilized and overprescribed. But what happened in the 1980s and 1990s was that there was a huge paradigm shift in medicine. And this did coincide with the hospice movement imported from Europe in the 1980s. There was recognition in medicine that we were not doing enough to help patients who were in excruciating pain, including patients at the very end of life. And there was this idea like, gee, maybe we're too stingy with opioids. Maybe we really need to prescribe them more often to alleviate suffering. And that initial idea was really a good one. What happened was that the pharmaceutical opioid industry got hold of that idea and then put a lot of effort, time, and money toward promoting certain misleading messages about opioids, namely that opioids, as long as they were being prescribed by a real doctor for real pain, that patients couldn't get addicted, which is not true. The other very misleading message that was promulgated by the opioid pharmaceutical industry was that opioids are good treatment for chronic pain, when in fact, there are no randomized placebo-controlled trials showing benefit of opioids in the treatment of pain longer than about 12 weeks.
Oh, wow.
So it's really important for people to know that the evidence, scientific weight of the evidence, doesn't support the use of opioids longer than about, honestly, 4 to maybe 12 weeks on the outside.
Oh, wow.
And that the longer that people stay on opioids and the higher the dose, the more likely they are to become addicted to opioids and to die of an opioid overdose.
Yeah, and so there's so many there's so many interesting information in your book, but if you could pick, one main message or piece of information that you hope that readers can, take away from reading the book, what would it be?
The one main message that I would want people to take away from this is to realize that anybody can get addicted to opioids. It's certainly true that some people are more vulnerable to addiction than others, but nobody is invulnerable to addiction. And that it's possible to get addicted to opioids, even if you get those opioids from your doctor being prescribed to you for a real medical condition and terrible, terrible pain. So having a medical condition and having pain doesn't make you immune to the biophysiological brain changes that occur when people become addicted. Simply being exposed to opioids for a long period of time, especially at higher doses, can make anybody vulnerable to the problem of addiction. So that's the first thing that I would want people to know. The second thing that I want people to know is that opioids don't really work for chronic pain. They're great short term, so 4 weeks or less. But if you take them every day, 4 weeks to months, they stop working.
Oh.
Not only do they stop working, but they can actually make pain worse because we become tolerant to the opioids, we become dependent, we can experience interdose withdrawal, and we can experience a phenomenon called opioid-induced hyperalgesia, which basically is just a fancy way of saying over time, opioids can make pain worse.
Oh, wow.
So what we're seeing now as we're slowly trying to taper chronic pain patients down to lower doses or off of opioids altogether, in many instances, if not the majority of those instances, their pain is improving on lower doses or once they're off of opioids. So I think that's really an important and powerful message. And it's a hard message to grasp because subjectively, when patients take opioids, they have a lot of positive responses typically. It alleviates pain, but it's also euphorogenic. It's also anxiolytic, right? People feel better mood-wise. Maybe it helps them go to sleep, or maybe it gives them energy to do the things they want to do. So subjectively, in the short term, we feel better, but in the long term, it can make us worse in many dimensions. Not just pain, also mood. It's been correlated with depression. It's been correlated with increased risk of suicide. It's been correlated with increased risk of hormonal problems. It's been correlated with increased risk of delayed healing. So when we give opioids after surgery, we may actually be delaying the healing process for our patients.
Wow, that's so interesting. I had no idea that it could actually not only it hinders you getting better in your recovery. It's so interesting. And so throughout your career, have you seen many changes in the field of addiction medicine?
Yes, I have. I would say the biggest change that I've seen is that insurance companies are now paying for addiction treatment in a way that they were not when I first started out. And that's really, really encouraging. So the Affordable Care Act, along with the Mental Health Parity and Addictions, Mental Health, oh boy, the Mental Health and Addictions Parity Act, which basically just said that insurance companies, especially those on the exchange, have to compensate providers for mental health and addiction treatment on par with the way that they compensate providers for other medical conditions. So that was really an important change, because it's hard to get doctors to go into treating a field if they're not going to get paid to do it, right? It's a long education. The vast majority of us graduate with medical school debt that takes years, if not decades, to pay off. I mean, you have to really be coming from an extremely altruistic place and maybe be willing to end up homeless if you don't get paid for the work that you do. So it was a huge shift that basically, when third-party payers, Medicare, Medi-Cal, and private insurers said, you know what, we are going to reimburse you to treat addiction. Huge, huge shift. All of a sudden, we started to see medical students interested in treating addiction, residents interested in taking an additional year to do an addiction medicine or addiction psychiatry fellowship, doctors in practice who have been practicing for some time saying, I'm interested in learning more about addiction. I see it in my patients. I realize for them to be well and for me to really realize my role as a healer, I need to pay attention to this problem. So that's the huge, huge shift that I've seen.
That's amazing. I'm glad that has happened. But kind of on the other side of that, what are some changes that you hope to see, particularly in the form of policy change?
So although we've seen progress in terms of getting reimbursed for addiction treatment, we're nowhere near where we need to be. It still can be very expensive. Some insurers will pay, others will not. The quality of what is paid for varies greatly. We still don't have good metrics about what rehab should be. Who are the kind of care providers that should be there? What is quality addiction treatment? How do we measure it? How do we measure those outcomes? How do we appropriately reimburse for the care that's being provided? Along those same lines, we still don't have a robust infrastructure inside of medicine to treat addiction. We still rely inordinately upon rehabs that are privately owned or nonprofit that are external to our medical system. So if a patient goes to an emergency room and says, hey, I'm withdrawing from opioids, can somebody help me? There's really not a good pathway for them. Most healthcare providers haven't been trained in how to treat addiction. When I say there's no infrastructure, it's like if you came in and had a heart attack, it'd be like, roll you to the ICU, we'll do algorithm B5 because you had these troponins and your EKG showed ST elevation in this lead. We know how to treat it. Somebody comes in diabetic ketoacidosis, we've got an algorithm. Every medical student learns it. We know what to do. Somebody comes in excruciating opioid withdrawal or a drug overdose or suicidal, we kind of go, I'm not really sure,
Yeah.
So we need to build that out at every layer. What we really need is just the way we have centers of excellence for cancer treatment or other healthcare problems. We need a real center of excellence for addiction treatment. So patients can go in with any type of addiction at any stage in their disease process and feel confident that they will have access to the standard of care and all of the different modalities that exist. Because of course, what's going to work for one person is not going to work for another. Just like this antibiotic might treat your pneumonia, but won't treat another person's pneumonia. So that's kind of what we need to have. The other really important thing is that we need to recognize that addiction is not just a problem of the individual, it is a public health problem, right? So we have rising rates of addiction across all demographic groups, across all ages, across all geographic areas. So we really need to figure out as a society, how do we prevent this problem from happening in the first place? How do we intervene at school level, at the community level to try to target this problem? I've talked a lot about the supply problem, which is the opioid overprescribing problem, but there's also the issue of, the demand problem, which has to do with the other risk factors for addiction, which are poverty, unemployment, multi-generational trauma, inadequate housing, co-occurring mental illness, all of these things.
Yeah, definitely. And I hope that, over the years we start to see more of that shift and changes in policy and public opinion in general, and that, there's not as much stigma around it going forward. And so thank you so much for taking the time to talk to us today. I know I personally have learned a lot, and I'm excited to put this on the website so that others can learn about this, because it is kind of a topic that I think is not discussed as much as it should be.
Well, thank you so much for your excellent questions and for inviting me to speak.
Yes, thank you so much. I really appreciate your time.